So what are those TTT?
Tetralogy of fallot.
Wonderful. Tricuspid atresia, TGV. Okay. So what happens is these are those defects which tend to increase or decrease the pulmonary blood flow. And the primary pathology arises either due to an obstructive lesion or due to abnormal anatomy, or even sometimes both. And the shunt is present is predominantly from right to left, due to which there's shunting of venous blood without passing through the lungs to be oxygenated. And that's why the unoxygenated blood will be circulating in the arteries, and due to which people may notice the patient is cyanosed, right? So a lot of people even say it like this: Lord Krishna had been having what kind of problem? He was a cyanotic kid. Hmm? So, anyways, I'll try to show you a beautiful animation. So, what do you notice in this beautiful animation? What is happening? As I said, CHD is all about imagining. You need not remember things. If you can see, you know it. So what happens is, as I was telling you, is this is normally the normal blood flow, okay? Superior vena cava, inferior vena cava, coming to the RA, going to the RV, then going to the pulmonary circulation, then finally coming through the pulmonary veins to the LA, then LV and systemic circulation. However, what will happen is those, due to the abnormal development of the fetal heart, especially during the first 8 weeks of pregnancy, a patient can sometimes develop four defects. Four defects will be VSD, PV stenosis, overriding of the aorta, and of course, right ventricular hypertrophy. So what was that? Those four anomalies, as I said it, VSD will be there, overriding of the aorta, pulmonary valve stenosis, and of course the RVH. So that is why it is called as the Tetralogy of fallot. So, so now you can notice the difference between the TOF and the normal circulation. So what is happening over here? As I already said, it's all about the imagination. If you are able to imagine well, you will not have any problems at all. So the typical presentations are pretty much similar like the other congenital heart diseases, but the babies, of course, will be blue. Yeah, and they become more prominent whenever the baby is crying or the feeding, in fact, and they will be again irritable. They can even faint. You can also notice clubbing of the nails, and the baby will have breathing difficulty as well. So what are the other differential diagnoses of clubbing? I hope you all were taught well, like CLUBBING. They all refer for something else. Okay, I would really like you all to read about it and keep it in mind because that's really important, as I said it. But anyways, during this, for this patient, for the TOF, what happens is due to pulmonary artery stenosis, the RV has to work harder to push blood into the lungs, thereby increasing the RV pressure and size. Due to the presence of the VSD, it tends to facilitate the blood to pass from the RV into the left ventricle, and mixing of blood takes place. And due to the overriding of aorta, what happens is the aorta tends to sit above both the left and the right ventricle over the VSD rather than just over the left ventricle. So as a result, the oxygen uh, poor blood from the RV can flow directly into the aorta rather than going into the pulmonary artery to the lungs. Okay. due to which there will be decreased pulmonary blood flow and poorly oxygenated blood, which tends to cause cyanosis. So, how do you diagnose? So, the patient comes to you. So, as I had said in the ASD, so in the ASD, what was happening? Wide and fixed split. In the VSD was pansystolic murmur. Then in PDA, continuous machinery murmur at the infraclavicular region. Now in the TOF, so the main concept in this is because of the pulmonary stenosis, you hear a murmur, which is present in this area. What is left parasternal region? So what type of murmur do you hear? So it is a ejection systolic murmur. Okay, and as I said it, the reason is due to pulmonary stenosis. So regarding the management, what can be done? So it's always advisable to wait at least till 6 to 18 months, till when surgical repair can be done. And as I had said it, so it involves closure of VSD with a tangential patch to correct the overriding, and also the pulmonary stenosis is relieved with a patch.